Okay, let me start to have the class. As you know, I sent you email, the friendly reminder that your research paper is due tomorrow, Wednesday, before 11:55 p.m. on Wednesday. I put 11:55. That is true. That it's, you know, very easy to know if it's Wednesday or Thursday, because if I put 12 p.m., students are thinking, oh, is it Wednesday or it's actually Thursday? So I just learn from students thinking, so therefore I put 1:55 or 11:55 or 11:59 on Wednesday, so that's fine. Please don't forget, you have to put it to digital Dropbox. You have to put it also to Turnitin. This is the ID number when you go to Turnitin, and password is relax, okay? And it will be sent to you again, that you will not forget about this. And we would like to have the hard copy on Thursday morning, yeah? So everything what you post on the digital Dropbox and turn it in, the same paper, please just do copy. It can be double-sided, on both sides, because we would like to save the paper, but we need to have the hard copy also. It's easier for grading, okay? Any questions so far for the research paper? You have great opportunity, and you had actually great opportunity to send actually also the draft, or, you know, having the comments from Jamie, from your teaching assistant, so to get some kind of input on the papers. I know that for many of you it's like the first year here at the college, so that you will learn the proper way to do the papers, okay? Also, I sent you email that everything is updated in the gradebook, so the gradebook was open, so you can check your points for the midterm and for your presentations. Also, I sent you email, we will have the guest speaker on Thursday, so please be sure that you attend the class, because it will be quite, you will learn, it will be very informative lecture, but also very entertaining lecture. So it's combination together, and you will be learning about the water, pollution of the water. So even if we have chapters about the water pollution, I will be not going too much into detail, because you will have the guest speaker. I will also upload the information about the guest speaker before the class on Thursday. So, any questions so far? Research paper, anything? Everything is clear? Wow, it's perfect, okay. Do you know that we are in the week 7 now? So just 3 weeks, and that will be end of the quarter, and yeah. Well, the APA, if it's written by AMA and APA format, it's only regarding the references. Okay, so it's not how the paper should be developed. So please be aware about that. And I actually, the AMA and APA, I wrote in that rubric in connection with references. So it's only connected with references, because I suggested how the paper should look like. So it's the single-spaced and just through paragraphs and the sections. So you have like 3 important sections there. Please follow that. You can just write the title of the section. You can underline that, bold that, and just writing, you know, the portion on that. References, yes, how do you write the references at the end of the paper, and how the citations of that references actually are inside the paper, okay? So either APA style or AMA style. Yes?
If we wrote an abstract, would you want us just to get rid of it?
Yeah, if you were writing abstract, well, I don't need to. Well, if you already wrote the abstract, just submit that, you know, separately, so I know that you did the abstract. But it's just because you wrote it already, but it will be not counted for the grade. So yes, probably if you have the to have the answer to your question is yes, not to use the abstract. Okay. Any questions? Anything? Yeah.
Can I print my hard copy on recycled paper?
Yeah. Okay, yeah, that's fine. So we just need to have the hard copy because it's easier, to read that. We can take that with us. And so, yes, if you have recycled paper, if you do the double side, so just saving the paper and everything, it's fine. So it's just because there is a lot of students in the class. We have 104 students, so it's a little bit easier to do that on the paper. So I try always to do as much as possible to save the paper. As you notice, it's single-spaced instead of double-spaced. I know that many of you already even started to write your draft in the double-space because in all the classes you have that. Now we are using the single-spaced, and you are welcome to use that on any, recycled paper. So that will be fine. Any questions? If not, so let's go to the chapters. So chapter 18. It's about maternal and child health. So as you notice in this class, PubHlth 1, Introduction to Public Health, we are really talking about different topics in public health. You probably notice also we are not going quite deep in with each of the topic because otherwise this class, I wish it will be for the whole 1 year, but it's introduction. So just to let you know, yes, well, maternal and child health, it's also part of the public health. So what do you think? Why it's very important to take care of the children? Why do you think it's very important that we as a public health providers, we really need to take, good care of the children? So what do you think? Why it's important? Why also sometimes when we check on the countries, we compare like infant mortality. What do you think if we compare infant mortality with different countries? What is telling us about that? So what do you think? Any ideas? I mean, first, if I can give you a little bit additional advice in that, or just like hint a little bit for that, of course, the children is the new generation, so it's the way how the country will be in the future. So therefore, we have almost like the obligation from public health perspectives to take care of the children. Also, infant mortality, if we are comparing the other countries, it's telling us what is probably the public health infrastructure. How is it possible to prevent diarrhea? It's possible to have good nutrition for the children. So therefore the infant mortality, like sometimes you notice also we are comparing the mortality rates also in the country. So it means like what is probably it's telling us what is the public health infrastructure, what is the healthcare system, what is the level probably education, because you can see all of this on that outcome, which is the health. So now we already talk about that. So now we are wondering why, if we are comparing the countries and comparing based on this, what is the public health infrastructure? Why health on its own, it's not as a priority all the time. Why, and we are going back, why we don't have the questions about the health, how we are leading the healthy lifestyle in our SAT tests. So again, we are going, on one side we are comparing the countries, on other side we don't have that basic education for the children and in that classroom and for the public. So if you look on that, so yes, of course, it's very important. It's the indicator also about the health of the country. So we need to be aware about that. When we look on the history of child health programs, and maybe some of you read the books 100 years or 200 years back, the novels or the time, how was the misuse, also the work of the young population, of the children. So Charles Dickens, any of you read any books from Charles Dickens, the time, how the children very young, at the age of 6, 7, they were working in the factories. And still there is the problem in some of the countries that young children are used as workers. So based on this, if you go back from that historical point, so you can see that was developed the specific public health policy that they were trying to take care of the children. So some kind of specific establishment, what is the age that the children can start to work or just be involved in that workforce. Also, now it's going a little bit back that we talk about prevention of not just chronic diseases, acute diseases, but also inborn diseases. So why we are doing the surveillance. So we would like to prevent birth defects. We would like also to prevent premature and low birth weight. So we need to do also education for the mother, how they should be taking care of their lifestyle, the nutrition, in order to have healthy children. Any of you are familiar with the sudden infant death syndrome? So this is the problem that it was not possible to found out completely the correlations that why the children before the age of 1 suddenly it looked like they are completely healthy and they were dying. So they were trying to find out many different things through the environment. And so one important thing was possible to find out to change the position of the baby to put to sleep. Now it's called like back to sleep. So before there was the recommendation to put the baby to sleep on the stomach. And so that was probably higher risk. That could be the regurgitation of the food and eventually probably the sudden infant death syndrome. Also, they found out that children living in that environment, there is the secondhand smoke, there is also higher risk that for development of sudden infant death syndrome. So there are many different things from the environment that they could increase the risk for the sudden infant death syndrome. Another thing is also they found out that if the children were with the parents, until the age of 1, also in that same bedroom, so they could a little bit listen to that breathing of the parents, so there was a little bit lower risk of occurrence of sudden infant death syndrome. So there are many things that we have to, if you think about that, it's a very natural process. It's quite unnatural that the baby is completely, when the baby is born and newborn baby and be completely on its own in the big room, not with the parents. So that some kind of unnatural things could eventually lead to increased risk of sudden infant death syndrome. Social factors and infant mortality. So as I mentioned to you when we were talking in the beginning, why we are actually concerned about the infant mortality. What is telling us this about the structure of the country? So it's also telling us from the public health perspectives, what is the environment? What is the public health policy? Is it possible to have higher risk of toxic components in the soil, toxic components in the air or in the water that eventually can increase the risk for infant mortality? What about the nutrition? So you also know about the breastfeeding. So breastfeeding is something that is it's the natural process, is the best sources for nutrition for the child and should be supported the minimum 1 year of the child. What happens sometimes in developing countries that the manufacturer with the infant formula were going there and telling and trying to support and giving the free infant formula and also supporting to use that instead of breastfeeding. So what can happen sometimes if it's free, so mothers are accepting that, they stop eventually breastfeeding, and then if they have to buy the infant formulas, they are very expensive. So what they start to do sometimes, they dilute that with the water. So what's happening with diluting the infant formulas? One is that the water probably is not drinkable, so it can be higher risk for diarrheal diseases, plus malnutrition, because if it's diluted, it's not a certain amount of the nutrients that the baby should receive there. So it's again, it's the trend now to support the breastfeeding as much as possible. When I was traveling with students in Costa Rica 2 years ago, we have guest speakers there, and they were talking about breastfeeding, that what's happening, what is the recent trend in Costa Rica is to stop breastfeeding because, do you have any ideas why probably it's decreased the breastfeeding in Costa Rica in recent years? Well, unfortunately, one word, it's not fashionable. So it's not fashionable. So it's not fashionable to have the natural birth, and it's not fashionable to the breastfeeding. So they notice in Costa Rica now with improving the wealth, that the population is getting wealthy. So if somebody who is wealthy, it's the status that, yes, I don't have the natural birth, I am doing the Caesar section, and I'm not breastfeeding. So now the public health providers are trying to educate the mothers. No, it's actually very important. If you are doing the breastfeeding, it's good for the baby, not just the bonding and improving the health, but also decrease risk for development of diabetes. It's decreased risk for mother also to have the breast cancer. So many good things and outcomes are connected with the breastfeeding. And with the Caesar section, something similar also, because through the research studies, it's possible to find out through the regular natural delivery how the baby is coming to the world, is all that things that the child is coming through the process is important for development of different functions, the good process on the physiological function of the baby. So you can see how fashion on its own could change, some approaches of that. So also when we look on the social factors, so another part is it really, are we sure that the environment is safe for where are growing up the children? Is it enough of prenatal care of the mothers also? Do they know what they should be eating, what kind of physical activity? Because maybe you could hear, in the past, the mothers sometimes are commenting like, well, I'm now expecting the baby, so I'm allowed to eat for two, to eat twice amount. It's not correct. So you have to eat based, on the needs, but also it must be healthy food. So they are all the things that they are connected with the maternal and child health. Also, of course, the prenatal care. So the mothers are going regularly on the check also, and it's very important to prevent any problems or any unusual situations during the pregnancy. As you know, also the consumption of alcohol, consumption of specific drugs, some of them are also, we are screening, we are doing surveillance, we are not recommending. There is no one single dosage of the alcohol that could be saved during the pregnancy. So there are actually public health policy and regulations to telling about this one, so it's very important. Process of immunization, so it's another part that you already know when you went to the school. So in order to go to school, you have to go through the immunization process. Also the immunization and check that the mothers are, healthy. Do you remember this one? Dietary supplements with folic acid. What kind of inborn problem could be caused in deficiencies of the folic acid? Do you remember that? Yeah. What? Yes, exactly. And it's very easy. You can have just the folic acid as a dietary supplement, and it's very easy to prevent that. Another problem that is during the infancy and during the pregnancy also is low birth weight. So this is another thing that is very important to give this information to the future mothers. Also, higher risk for low birth weight is with the adolescent pregnancies, so teenage pregnancies. So this is something that we would like also to decrease the risk for that. Family planning, this is, if you will be traveling to any developing countries, family planning as a public health provider, this is something that you will be quite involved in that. Because again, it's very important from the perspectives that the family really can have this amount of the children there, that they can take care of the children, there is enough of food, and the children are growing in a safe environment. So this is very important. What do you think, or did you hear about the specific education at the schools a few years ago, or the approach about completely the abstinence? That was the education and started the process in the high school. In short term, it was possible to see like decrease of the teenage pregnancies, but then was coming again up. So from the public health perspectives, you have to do completely education. You have to do education from all perspectives for the young population and lead them that they will pick up the right choices. So if you do some way of the forbidding, or you are just telling them no and doing the abstinence and not explaining all situations in case there will be the situation how to do the family planning, that will be not proper way from the philosophy of public health. From the public health perspectives, everybody needs to have the education, and based on the education to make the right choices about that. And so there are the things that is very important to explain to the public and to the teenagers, and the part of that family planning, different form also of contraceptives. Do you remember when we talk about, that was the situation in Los Angeles, that was the risk. We have actually few of the slides in the past talking about public health providers developed a program. They wanted to decrease the risk of development of HIV and AIDS. So in that first years, they were thinking, well, a lot of people that they are addicted to the drugs, they are higher risk because of that sharing of the needles. So there is the higher risk for AIDS and HIV. So there was the initiative to give the clean needles to this type of population for the drug addicts. And there was some controversial things telling like, well, what the public health providers are doing, you are actually increasing and supporting the addictive behavior. So it was seen from one of the opponents. If you see that from public health perspectives, it was not, because one thing was that if you were giving the clean needles, so you eventually were able to get that addicts from the streets and maybe help them and tell them, well, you need to go to rehabilitation clinics and just monitoring that. Plus also giving them clean needles, so decreasing the risk of sharing that and transmitting and increasing the epidemics of HIV and AIDS. So something similar is also with the family planning. So if somebody would thinking like, oh, we cannot talk about that, we cannot do and talk about the contraceptions, if we will do that, we are actually enhancing the activity. It's again not true, because you have to give the whole explanation. You have to prepare the individual person on any situation that will happen in the life, and hoping that the person will, pick up the right choices, but the person needs to be educated about everything. So this is the approach from public health, that sometimes you will see it can be challenges, there can be opponents, that can be, quite controversial things about that. But again, you are public health providers, and what is important from your perspectives is to give the education, to help the person, to explain everything, education, prepare the person, whatever situation the person is, and helping and leading that the person will make the right decision. But they need to be educated about everything, okay? Any comments for that? Okay. So also, as you know, to improve the health of our children and improve the health for maternal and child health, the government is taking part also. It's involved in that different programs, developing the different programs. If you look on that, it's WIC, so it's the WIC program. So they are giving and support the food for the families with the children. If you look on the other like school meals programs, food stamp programs, only one problem is sometimes if you look on that, and I don't know if you are familiar with type of the food that they are inside the school meals program, it's not always healthy. Of course, it's the program that the people or the children are not hungry, but now we already know there is the education to find out what type of the food. So it doesn't mean that I will be giving just high-fat, pizzas or something. I should be aware also about that and giving the healthy food. Or even with the food stamps program, it should be correlated with the healthy food. So there is still a little bit gap in that. I mean, it's great thing is that the people that, taking care in this way, that there is the caloric, amount of the food, so the people are not hungry, but it's important that they should have healthy food also. So that's something that is waiting for you to do some changes in that. Nutrition Network for Healthy Californians. So it's a great program. A few years ago, I was working through the Public Health 198 class with my students. We went to Santa Ana School District. So, for example, Santa Ana School District, based on the socio-economic situation in that area and the school on its own, they classified for this, qualify actually for this Nutrition Network for Healthy Californians. So what this program was doing, this was program for every 3 years. After 3 years, that was the evaluation of the program, see again if the school district qualified for that and if there was possible to do some improvements. So part of this was, for example, they were receiving pamphlets and education information about the healthy food that was giving to the students, to the parents, and they also have additional money to develop like healthy learning, teaching the students about the healthy food, so they could have the healthy breakfast, or they were having also cooking class together. And once a month, if this was, for example, like month October was the persimmon month, so they were able to get the free persimmons, doing the cooking from that, and inviting also the parents and children. So actually the children together with the parents were cooking. Okay, so this was like the message to learning, about the specific type of the fruit or vegetables, and then some kind of bonding also between the parents and children, that yes, we were talking about the same type of the food. So another thing is, if there will be more and more education about nutrition at school, so children will bring that information back home and eventually will try to influence the parents sometimes to bring that healthy food too. So it will be working from both sides, from parents and from the children. So this was quite nice program that we were involved in that also with our students. Another part is children's health and safety. Of course, it's the immunization. It's to be sure that if they do the physical activity, they are doing that in the parks. It's the safety for the children, safety for the environment. Okay. So now I started with this question in the beginning. Now you can answer that. Why is the health of infants and children of special concern for public health? Now you can answer that. If there will be the question like this on the midterm, and it will be A, B, C, D, maybe. So what is your answer? Why is that? Anybody? Why it's important? Why we need to take care of them? Yes.
Because in the future, the children can be public health providers themselves, and the children, when they grow up, they're the ones who are going to be shaping the community.
Okay, and thank you so much for sharing that. And of course, I just would need to share one information with you. I mean, this is like a little bit in the joking way. It's a little bit selfish in that way, because I'm thinking like, well, I need also to have, that you have the right education about public health, because you will be taking care of us. So whatever the children will have, they will be taking care of you, okay? So it's the process. Now you have that information about public health, and maybe 10 years, 15 years from now, you will be taking care of me somehow. Even you are not realizing that, but yes, it will be probably, if I will be still able after that 10, 15 years to drink water from the fountain, or I will be still able to breathe, the fresh air, and there will be no pollution in the air. So if I will be able to do that, it will be, up to you if you will be continuing and improving the public health policy and doing something like that. So how will be my life 15 years from now? It depends what kind of information, how I will be educating, my students in the class. So indirectly, yes, you will be taking care of me. So, okay. I would like, do you remember we were talking about, in the previous chapters, about the health behavior. And I was promising to you to show you the short video clip from Dr. Dean Ornish. I mentioned that during the time when I was talking about the health behavior, and when I was talking about the importance of nutrition, physical activity, lifestyle. So I would like to show you a few minutes. I think it's probably 10 minutes. As you can see, it's quite long presentation. discussion here. If some of you would like to continue, you are welcome to do that on your own. But I just wanted to show you in the beginning a few new approach for lifestyle modification. Mostly until Dr. Dean Ornish started with completely new approach, the approach was like, well, if you are not keeping yourself, eating healthy food, physical activity, if you are not doing this, you are increasing risk for development of chronic diseases. So everything was in that way. So if I'm not doing that, it's chronic diseases. But if we talk about that, especially when I talk that here in front of your, that class, and you are young population, and I will tell you, well, if you are not keeping, enough of hours of sleep and you are not eating healthy, you are increasing risk of development of diabetes or cardiovascular diseases, maybe at age of 40 or 45. If I mention to you age of 40, 45, wow, it's cyberspace, it never happened. Believe me, sometimes it happened. So this is, you cannot identify with that because it's quite far. You can a little bit identify if I will tell you, well, it's, what are you doing today? That will be your mood tomorrow. Or what are you doing today with, antioxidant, if you are eating enough of anti-inflammatory diet and antioxidative diet, you will be probably able to think better and maybe memorizing better, and maybe you will have A on the final exam. So if I tell you this, you can identify with that. So, or something that you would like to feel good. But if I'm not sharing in that direction the information, it's so far. Even you are educated, even you understand everything, you are learning that for your class, but still it's completely not connected with you, with your personal health. And remember, you as a public health provider, you also need to be as a role model in public health. So it's quite unusual profession. So I would like that you will listen now to Dr. Dean Ornish. Please listen carefully, and we will have few minutes discussion after that.
It truly is a distinct pleasure to introduce Dr. Ornish. I can remember when I was a medical student, hearing about this young cardiologist who had shown that heart disease could actually be reversed with lifestyle. I can remember being excited about it then and thinking this is really changing the paradigm. That was, we won't say how many years back, but quite a few years back. And since then, Dr. Ornish has continued to change paradigms. He's done seminal work on cancer and how lifestyle can change cancer with his work in prostate cancer. And more recently, seminal work on genetics and how lifestyle can change the genes that we walk around with. It's not very many people that you can point to and say, 3 times you've changed the paradigm or helped to change the paradigm. But I believe Dr. Ornish has done that in his research. What's fascinating to me also is that Dr. Ornish has recognized that research alone is not enough, and he's been working to change policy. Through his work, the Center for Medicaid and Medicare Services has shifted how they're reimbursing cardiac rehab. And he's very well connected with a variety of organizations working both within public health and outside of public health to change how we approach healthcare. I appreciate your energy, I appreciate your commitment, I appreciate you being here. Dr. Ornish was originally scheduled to be here yesterday. He had a conflict but went out of his way to come today, and that means a lot to us. So thank you so much for being here, and we look forward to your talk on personalized health care. Just one other comment, Dr. Ornish has hundreds of awards and presentations and things. You can read that if you want more details in the Glenn Bix Memorial Lectureship on page 6 of your programs. Welcome, Dr. Ornish.
This was from the conference at the School of Public Health, Loma Linda University. Healthy people.
Can y'all hear me okay? I'm using this device. Thank you, Wayne, for that kind introduction, and also to your father, Bill, who we have 2 generations of Dysingers here today who have inspired me as well. And also to Dr. Kraus for organizing this, and to Dr. Penner as well. So I just feel very, very appreciative for the chance to be here today. What I want to do is to cover more than 30 years of work in about 45 minutes and to talk how this all ties together. But I want to start by talking about what we've learned that enables people to make sustainable changes in their life. You know, when I first started doing this work, the idea was that nobody could change it, and even if they did, it wouldn't really matter anyway. Now it's like, well, you know, your patients changed, but you live in California, it's an altered state, you know, they'll do anything here. This will never play in Peoria. And so what we've learned is what really does enable people to make these changes. And it's not what I thought. And whatever wisdom I have has come from doing this for so long and making so many mistakes and learning from them. And I want to share some of those things with you, what we've learned. And the bottom line is this: it's what's sustainable is joy and pleasure and freedom. It's not fear of dying, it's joy of living. And there are a lot of false choices that we think about when we talk about making changes in our diet and lifestyle. You know, is it, if I make these changes, am I going to live longer, or is it just going to seem longer? You know, that's kind of the standard joke. When I was consulting with one of the big food companies, they would say, these are our fun for you foods and these are our good for you foods. And I say, well, that's the problem. Why isn't it fun for you to look good and feel good and have more energy and think more clearly and do all the kinds of things that really matter to people? Even the language that we use when we talk about changing diet and lifestyle, we talk about food in a moral sense. You know, these are our good foods and these are bad foods. And it's a very small step once you categorize foods as being bad foods to thinking of yourself as a bad person. So you might as well finish the pint of ice cream once you go down that road. Even the word compliance, which is often used in behavioral change, has this very fascist quality to it. It's all about manipulating behavior and forcing behavior, whether with yourself. Even willpower is all about, you know, what you can't do and what you must do. And that's not sustainable, because even more than feeling healthy, we want to feel free and in control. And so the idea of having to manipulate behavior is not sustainable. But the concept of a spectrum is all about we have a spectrum of choices, as opposed to a diet. Even the concept of diet, what you can't have, what you must do. If you go on a diet, sooner or later you're going to go off it. It's not sustainable. This goes back to the first dietary intervention that failed, you know, when God said don't eat the apple, and that didn't work, and that was God talking, so we're not going to do better than that. So if you talk about a spectrum of choices, which I'll describe more fully later, there are no good or bad foods. It's not a moral issue. There are some foods that are healthier for you than others. That's a very different connotation than good and bad, and I think that's important. Even when we talk about risk factor reduction, that's just so boring for people. They say things like, I don't care if I live longer, I want to enjoy my life, you know. And again, joy is really a much better motivator than fear, because fear is too scary to think about. You know, we're all going to die. I don't want to be the first to break the news to you. You know, the mortality rate is still 100%. It's 1 per person. And so it's not something you think about most of the time, because, you know, it'd be too overwhelming. So we've just learned that efforts to try to motivate people to change that are fear-based are not sustainable. I mean, if you had a heart attack or some chronic disease, for a few weeks you'll do anything because the denial has broken down. But even then people tend to go back to their old patterns. And doctors say, oh, I can't even get my patient, he just had a heart attack a month ago, to eat less red meat. How do you expect him to make bigger changes? And that's because they're trying to scare people. If you don't change your diet, you're going to get a heart attack. If you don't quit smoking, you're going to get a stroke or lung cancer. Nobody wants to think about those things, so they don't. So I love this cartoon. She says, I give smokers a discount because there's not as much to tell, the fortune teller. That's the fear-based approach that doesn't work. And, you know, this is the rap I get. This is from a New Yorker cartoon. It's, you know, then the evil witch tried to lure the children into a house made of onion rings, barbecue potato chips, and bacon cheeseburgers. And the kids all, you know, freaked out. I mean, I can't go out to dinner with someone either apologizing for what they're eating or commenting on it. I'm saying, look, I'm not the food police. I don't care what you eat. That's really your business. But this whole idea of food as a moral issue really gets in the way. It's not really what's sustainable. But what the good news is that you don't have to wait very long to see the benefits. And there's no point in giving up something that you enjoy unless you get something back that's better and quickly. And because I mean, this is my wife. We have an 8-month-old baby girl and a 9-year-old son. How many of you have at least one kid? I'm just curious, raise your hands. Was that a big change in your lifestyle when you had your first child? Was it harder than you thought? Was it a lot harder than you thought? How many of you have more than one child? Did you forget? Or were you just careless? The point is that so often people say, oh, they don't want to make lifestyle changes, it's too hard. But you know, having a kid is a really big lifestyle change. All the sleepless nights, all the money you put away for school, You know, you can't just throw them back. I mean, you're stuck with them. And yet people do it, and even more than once, like we did, because it's worth it. And so the task for us as health professionals is to help people connect the dots between what we do and how we feel. Again, there's no point in giving up something that you enjoy unless you get something back that's better and quickly. And because this awareness is really the first step in healing, helping people connect the dots between what they do and how they feel. Oh, when I do this, I feel good. When I do this, I don't feel so good. Maybe I'll do more of this and less of that. And what's encouraging to me is that science is a very powerful way of raising awareness to help people see these new possibilities and how quickly they can feel better. Because the mechanisms that we look at are much more dynamic than we had once realized. And we can use these very high-tech, state-of-the-art measures to prove the power of these very low-tech and low-cost and often ancient interventions. And to show people that your body often has a remarkable capacity to begin healing itself, and much more quickly than we had once realized, if we simply stop doing what's causing the problem. And everything that we did was thought to be impossible when we first started it. And we realized that because these mechanisms are so dynamic, you don't have to wait very long to see the benefits. And then it becomes sustainable. It goes back to what I first started with, because you feel so much better so quickly. It reframes the reason for change from risk factor reduction, which is boring, or fear of dying, which is too scary, to joy of living, and joy and fun and pleasure and freedom are what are sustainable. So let me give you some examples of that. When you eat healthier, when you manage stress, when you quit smoking, when you exercise, when you have more love and intimacy in your life, your brain actually gets more blood within minutes to hours. And not only does it get more blood, so you think more clearly, you have more energy, you need less sleep, but you can actually grow so many new brain cells in just a few months that your brain gets measurably bigger. It's called neuroplasticity. This was thought impossible just a few years ago. And what's nice is that some of my favorite foods and substances increase neurogenesis. And what's bad for your heart is also bad for your brain. So saturated fat and sugar and nicotine are not only bad for your heart, but they decrease brain cell production. Whereas things like green tea and chocolate and blueberries and modern alcohol consumption increase neurogenesis. Stress management improves your brain. Chronic stress actually decreases it. Even cannabinoids, believe it or not, increase neurogenesis. You know, I'm just the messenger here. What were we just talking about? And so walking just for 3 hours a day can cause so many new brain cells to grow. And this is in the Proceedings of the National Academy of Sciences and Nature Neuroscience, and some of the top-tier science journals are showing this. This is not fringe research. This is really coming into the mainstream. Tango can increase neurogenesis, whereas chronic stress actually decreases brain volume in ways you can actually measure. So these are not subtle findings. And it's selective to parts of your brain like your memory that the hippocampus controls. And it's one of the reasons why when you're under chronic stress, it's hard to remember things as well. It's actually affecting your brain in ways that are measurable now. Your skin gets more blood when you eat and live more healthfully. Christy Turlington's father, the supermodel, died of lung cancer. And so she has this wonderful website called smokingisugly.com because nicotine, besides constricting the arteries in your heart that can cause a heart attack, or in your brain that can cause a stroke, constrict the little capillaries that feed your face. So you wrinkle faster, and so you age faster, and you have that gray pallor. And so that, for many people, is more motivating than talking about living longer. And likewise, your sexual organs get more blood flow. Nicotine constricts blood flow not only to your face and to your heart and to your brain, but to your sexual organs. It's the anti-Viagra, and one of the most effective anti-smoking ads. And I know in Dr. Fielding's very visionary work, I mean, were you responsible for this ad, or did that precede you? This was actually the Department of Health Services in California that ran these ads. Was that you? So, you know, it doesn't say emphysema, lung cancer, heart attacks. It says impotence, because smoking is marketed as being really cool because it makes you sexy and it makes you beautiful. But it doesn't make you sexy and beautiful. It makes you ugly and impotent. So how fun is that? And so if we can, again, help people raise the awareness of what these choices are, not in the long term, but in the short term, and it really goes to the heart of what really motivates people, which, again, how pleasurable is it to be impotent? How pleasurable is it to be aging, 20 or 20 years faster? And then it really becomes much more manageable and much more sustainable. Your heart gets more blood flow. As Wayne said, we're able to show that even severe heart disease can begin to reverse when people make these changes. This is a representative patient using a quantitative arteriogram, looking at where the arrow is in the upper left, showing the narrowing. The percent diameter stenosis is very small, just a year later, you can see it's wider. And because perfusion or blood flow is a fourth power function of the diameter, even small improvements get magnified. So you can see on the lower left is a cardiac PET scan showing blood flow, and blue and black is no blood flow. You see there's a big part of the heart that's not getting any blood. And the lower right, a year later, it's almost normal. Clinically, this is a guy who literally couldn't walk across the street without getting pain, and by the end of the first month was essentially pain-free and was climbing 120 floors a day on a Stairmaster. That's not unusual. That's really more the norm when people make big changes. And that's what makes it sustainable. Because he says, I like eating cheeseburgers, but not that much because I feel so much better. Again, it's about what you gain is so much more than what you give up and how quickly you can experience those benefits. We found that when we looked at all the arteries in all the patients, blindly analyzed, randomized control study, the arteries got worse after 1 year and even worse after 5 years in the control group. And they were making the usual changes that most doctors recommend, at least at the time. Whereas the experimental group that made much bigger changes showed some overall reversal after 1 year in the lower green line, and even more reversal after 5 years. So we published that in the Lancet and JAMA and Circulation, American Journal of Cardiology. And one of the most interesting findings to me was that the more people changed, the better they got. And this is a theme I'm going to come back to. I thought, mistakenly, that the younger patients with milder disease would be more likely to show reversal, but I was wrong. It wasn't a function of their age or their disease severity. It was only a function of their adherence. And the older patients, the oldest one is now 96, improved as much as the younger ones. That's a very powerful and very optimistic message to give people. It says, look, if you're alive, in most cases, it's not too late. Whether you're 46 or 96, if you're willing to change, the more you change, the better you get in ways we can measure. The dose response across both groups. And we found that also with prostate cancer, which I'll talk about in a moment. I got this as a Christmas card a few years ago from two of the men in one of the hospitals that we trained. The younger brother on the left is 88 and the older one on the right is 92. They wanted to show me how much more flexible they were after doing their yoga. And the following year, they sent me this one, which I thought was pretty funny. So, unretouched. So you just never know how much better people can get at whatever age they are. We found a 40% reduction in their LDL cholesterol. This is comparable to what you can get with statins but without the costs and side effects. And last year, Americans spent $20 billion just on Lipitor. So if we're talking about health reform, which I'll talk about more in a moment, we need to say, where can we intervene with lifestyle as treatment, not simply as prevention, in ways that can not only be more medically effective, but also more cost-effective as well. We also did a randomized controlled trial showing that these same lifestyle changes could stop and even reverse the progression of early-stage prostate cancer. We did it in collaboration with Dr. Peter Carroll, the chair of urology at UCSF, and the late Dr. Bill Fair, who at the time was the chair of urology and urologic oncology at Memorial Sloan Kettering Cancer Center. And we took 93 men who had biopsy-proven prostate cancer, randomly divided them into two groups, and these are men who had, for reasons unrelated to the study, elected not to be treated conventionally, what used to be called watchful waiting, and it's now called active surveillance. And then we could look at the effects of lifestyle alone without being confounded by chemo and radiation and surgery. And what we found after a year, and the PSAs were run at Sloan Kettering, we drew the blood in San Francisco and overnighted it to them. PSA went up and got worse in the control group, went down or got better significantly in the experimental group. Now, it's not a huge drop, but in prostate cancer, if the PSA doesn't rise, then generally the tumor isn't spreading. And if the tumor isn't spreading, you're going to die with prostate cancer and not from it. We found again, the more people changed, the lower their PSA went. And the same kind of dose response across both groups, a very powerful, optimistic message. When we added their serum to a standard line of prostate tumor cells growing in tissue culture, the prostate tumor growth was inhibited 70% in the experimental group and only 9% in the control group. And one of the most interesting slides is, again, we found a direct correlation with the degree of reported lifestyle change and the degree of inhibition of tumor growth. The more people changed their lifestyle, the more it directly inhibited the growth of their prostate tumor. And we did MRI and MR spectroscopy to look at the tumor activity in a subgroup of patients. And this is a representative patient. You can see the tumor activity of the prostate cancer shown in red diminishes a year later, as well as the PSA coming down. Now, we were wondering, how is it that that can happen so quickly? And so we wondered if there was any change in gene expression that might occur. And what we found was that in just 3 months, in another group of men who had biopsy-proven prostate cancer, so we could look at that, we found that over 500 genes were affected in just 3 months. And in every case where we figured, when we knew what the gene did, it went in the right direction. In simple terms, upregulate.
Okay. So, I know we cannot have the whole times through this presentation. But isn't that powerful to hear something like that for the public health? Isn't that something that maybe we should more concentrate in that way? I just wanted to ask questions. Did you have any experience that you started to, or when you talk with other people also, did any of you have an experience thinking like, well, I should be thinking like how I'm feeling at this moment with changing the lifestyle? Or always all of you were just able to hear like, well, if I'm keeping this lifestyle, I am preventing the chronic diseases? Did any of you have any other approach instead of only the chronic diseases, thinking like how I feel at this moment? So that's quite new for all of you, this approach, the sustainability in that. Yeah. So this is again, I mean, this was presented on the conference 2010. So it's still quite new approach in that direction. But this will be something that people should realize that, or also you as a new, public health providers, to get with some kind of message like this to the public and explaining like how they feel on everyday basis. So how instead of thinking what can be really happening in the in the future. So it's quite powerful. Okay. So now I would like, so that was the part that was connected still with the lifestyle and with behavioral. Before I will go to another video clip, I have short video clip also about the trans-theoretical model. I would like a little bit to do introduction on the chapters about the environment. So that, as you know, we will have the guest speaker on Thursday talking much more about the water and pollution of the water, but I would like a little bit to start with the introduction on environment on its own. So you can see from these perspectives what you are able to listen to all of the different topics in public health, that environment is also one part. So what everything belongs to the environment. Of course, it's the pollution in the water, it's the soil, it's the environment, everything around us that could also influence by toxic components our health and increasing risk for the diseases, chronic diseases, or increasing risk for connection with the viruses or pathogens for infectious diseases. In order to a little bit organize the environmental health, we have to have also public health policies. Environmental hazards. So this is very important. There will be questions on the midterm, so this is something that you need to know what belongs, what are the part of environmental hazards. As you can see on that, it's radiation, mercury, lead, asbestos, pesticides, and many of that things, it needs to be developed, the public health policy, that they are established and they are enforced. The Environmental Protection Agency, EPA, this is one of that agencies. It's very, very important. You will find all the information there. For example, if you will be working on maternal and child health, and you will receive the phone calls from the mothers to ask you, well, I am consuming the fish. I know the fish could be contaminated with mercury. Can I consume fish or not? Because if I'm consuming fish, it's omega-3 fatty acids, it's decreasing risk for cardiovascular disease, it's improving my health. So one thing your response will be probably other sources that are connected with omega-3 fatty acids, so not just the fish, so from the vegetarian type of eating. But also you will go to this agency and you will find the list what type of fish have the lower level or the lowest level of absorption of the mercury. And then you find out there are maybe smaller fish, they have smaller amount. If it's bigger fish like shark, that will be huge absorption of mercury. So you will many times this information or this resources use for information for your clients or for the mothers. So the EPA, it's like very important side. Now when we talk about the mercury, we already a little bit talked about that in connection with Minamata disease. This was about the childbirth defects also. That was the first when we mentioned that. Many of these toxic components are connected with neurodegenerative problem or neurologic damages on that human health. this is already, we talk about that. Mercury, I don't know, there should be a site, I don't know why it's not available to see that, I have to check that. So there are different sites, websites also that you can do the special laboratory testing for the mercury. What could be the sources for the mercury? It can be the emissions, it could be from other industry. We can get as a pollutant the mercury, especially from different electronic equipment. Here are the little bit examples and pictures. What is the expression of the disease? Sometimes was connection about dental fillings, so that was going the absorption of the mercury to the body, so it was changing now the fillings. Vaccines, it was long time ago, was thinking like that mercury was used like keeping the vaccines for a prolonged time on the shelves. But now it was changed from back like 1997, so there are different components added to the vaccines. So there are some controversial things that what could be the sources of mercury. Radiation, we already know that ultraviolet lights from the sunshine or from the sun could be connected with risk of that development of the skin cancer. But sometimes when we think about it and we do protection in that way, we have to be aware how far we are going, if it's paradoxical or not, because on certain level we need also to have the being exposed to the sun, because we need to develop the vitamin D3, the activated vitamin. So recommendation would be probably like 15 minutes to be exposed to the sunshine. But if it's a longer overexposure and if there are additional lifestyle factors that they are increasing the risk of developing to the disease, that is even enhancing the effect, negative effect of the sunshine. Radiation, yeah, I already mentioned about this one, about different changes on the skin. Lead, it's another risk component from the environment. That can be connected with different diseases. Mostly, many of these components are connected with nervous system. Based on that research, it was possible to find out it's important to develop the public health policy to prevent the exposure of the lead in the soil and having the risk for the human beings. Actually, when you look on that contamination in the drinking water, so that was the development of, based on that research. So from 1977, they started to develop the new pipes in the housing in order to prevent the contamination, because it was coming to the drinkable water. Pesticides. So if you look on that, it's something that we need to be aware about that. DDT, that was quite successful. It was possible to use that for decreasing the risk of malaria, but it was possible to find out that it's still staying in the soil, and especially it's soluble in the fat. So if the person was in that area that was the spraying done with the DDT, and the person have higher percentage of body fat, it was higher risk that was exposed and absorbed the DDT. So if you look at that's another thing, therefore we have to develop from public health perspectives the policies to decrease the risk to be exposed to different form of pesticides. Asbestos, so it's another component as a hazard in environmental health, and so based on this, it's connected with higher risk of having the problems with the lung disease. So that again, it's very important to develop the public health policy to work and decrease the risk of exposure. Okay, so that was, I put it here. Another component, persistent organic pollutants. So that's the risk also what we have in public health, that some of the components are not degradable, so they are staying. And it takes a long time before they are completely solved and dissolved in the environment. Occupational exposure, I would like that you remember this. Because if we go back now and you are thinking, okay, how we were able to get that information that mercury maybe has the side effects, the asbestos, we got this information from occupational exposure. So first, the workers, if they were working with any of that components, so because it was higher concentration and they were exposed to that contaminants, so suddenly the disease was connected with the workers in that specific area. So based on that, of course, it was possible from public health perspectives to find out, well, this exposure, even if there will be a smaller amount and long period of time, it can cause similar effects of that. So I would like that you remember that workers, we call that like guinea pigs. So it means that they serve in that way because all of these now public health policy that were developed to prevent occurrence of the disease for the public was unfortunately, based on that exposure, higher concentration and symptoms of the disease of the workers with the specific components. So I would like that you also remember this different type of the cancers connected with exposure of some of the pollutants. So it's very important. They are the basic occupational exposures. At the factory farms, there are also the risks from the air pollution. So it's very important to develop and do new suggestions how the farms should be established in order to decrease that, because it can be higher risk from the specific farms, not just for the pollution, but also toxic components in the water, pathogens in the water, and spreading of the disease. Setting standards. So here now, what you were able to hear in the beginning, it was just like introduction, what is the environmental health, what we need to be aware about that. And we need, based on this, remember also it was in public health, to do the assessment, based on the assessment, prepare the recommendation, and then to put the recommendation back to the practical structure. So setting the standards, developing the public health policy, so it started through different steps. It was different acts, and eventually developing and enforcing public health policy. You have like Clean Air Act and Water Clean Act also that you will hear through our guest speaker. So now when we talk about risk-benefits analysis, sometimes it's the same like when I talk about tobacco, and when we did the public health policy, sometimes in the beginning it looks like, well, for the manufacturers or for that people that they need to develop these specific restrictions, and they have to lead and follow the public health policy, and they are the manufacturers, so they could feel like resistant because they think that they are losing the profit. But eventually, if you calculate it in the long run, it's good for the population because population will be healthy. So that's analysis that is necessary to do that, and it's not always seen, from the government and from the recent politicians. So these are the part of the challenges that you will have, in the public health. So discussion question 1 for the environmental health. Most environmental hazards like infectious pathogens must reach human hosts if they are to cause harm. Think of 5 or more environmental agents that can cause disease in humans, and for each describe 2 or more ways by which people may be exposed to them. So we don't need to go completely in the deep in that, but do you have any examples, what could be for environmental agents, what I was just covering? Any idea? Yeah, go ahead.
E. coli and salmonella, I'm seeing it come a lot from places other than just like meat or the usual like eggs. You're seeing it a lot in spinach plants because in the fields, I guess they use manure and they aren't cleaning the plants properly.
Yeah, thank you so much. So that will be example about the farm. Do you remember I was talking also about one part? So it could be chemical components from the factories, but it could be also farm on its own. Okay. So now I wanted also to share with you another video clip. I don't know if I have, okay. This is for 5 minutes video clip. Remember I talk about Dr. Prochaska and about also trans-theoretical model. I think it's quite important for you to see this portion because again you will be influencing. This is connected with environmental health also, and it's lifestyle management.
Ladies and gentlemen. My name is Mary Ann Farkas, and I'm the Director of Training at the Center for Psychiatric Rehabilitation at Boston University. Welcome to the third presentation
on quality of life.
Okay, so
And
Dr.
we shall see
Prochaska.
also the major cost drivers in healthcare. We've known for decades that behaviors like smoking, alcohol abuse, sedentary lifestyles, diet, stress, depression, chronic hostility, that those have been the major causes of chronic disease and premature death. But more recently, we have seen how they impact on healthcare costs. In the United States, healthcare costs are $1.2 trillion a year, going back to double-digit inflation, in part because our managed care organizations have invested heavily in cutting costs. They've invested very little in preventing costs. Of those totals, pharmaceuticals account for only 8% of total healthcare costs. Behaviors account for 60%. But the way that mental health services have been delivered, the way that behavior medicine has been practiced in the United States, we impact effectively on less than 10% of those costs. So if we are going to impact on the quality and quantity of life for growing numbers of people and on the growing healthcare costs, we will need to develop services that can reach entire populations, not just individual patients. Here's some examples. When managed care offers state-of-the-science smoking cessation programs for free, removing price as a barrier, the percentage of smokers who participate nationwide is 1%. If we offer home-based programs where people can use them at home and not have to go to clinics, which is a real barrier, we can get that up to 5%. If we look at mental health services, national statistics are clear. People with DSM-4 diagnoses, less than 25% ever receive professional services in their lifetime, let alone for any particular episode or problem that they are facing. Part of the problem has been our very paradigm of behavior change. In the US, we are a very action-oriented society, and so we historically define change as equaling taking action. Somebody changes when they quit drinking, when they start to take medication for depression, when they begin to lose weight, when they go for help with rehabilitation. And that type of action paradigm is, as we shall see, part of the problem. About 20 years ago now, we were taught by about 1,000 ordinary Rhode Islanders a very different approach to change. We followed these folks for 2 years, looking at their successes and failures. And these people taught us something about change that was not in any of the 300 systems of psychotherapy, counseling, behavior change. They taught us that change involves progress through a series of stages. We don't throw out all that we learned about action over the last 50 years, but rather we integrate it as one of 6 stages. And so change is not an event, but rather it's a process that unfolds over time and involves progress through these stages. We'll take and briefly look at the nature of these stages and then see how we can apply this alternative paradigm to help many more people than we ever imagined possible. We start with pre-contemplation. This is a stage in which people are not seriously intending to take action in the foreseeable future. We usually measure that as the next 6 months. We will see that people in this stage underestimate the benefits of changing, they overestimate the costs, and they're typically not conscious that they are making that mistake. And if they're not conscious of that, the chances are that they will be stuck in this stage for a long period of time, doing damage to themselves or to others, to quantity or quality of life. Historically, we label these patients not motivated. We label them as non-compliant, resistant, not ready for therapy or for our services. We now know that it was us who were not ready for them. It was us who were resistant to change in our services to match their needs. And it was us who were not motivated to understanding what their needs were so that they could progress and participate in the change process. We will see that these are not like stages of child development where children seem to be motivated internally to progress from one stage to the next, like our grandson who, when he was crawling, was getting about in the world very well, yet was clearly driven and motivated to progress to walking, even though he had to fall on his face, had to experience failure, still was driven to master the next behavior of walking. We find only 2 naturally occurring forces in our research that can move people out of these stages. One we call developmental events, so that in our research, the mean age of smokers finally reaching maintenance is 39. And those of us who've gone through age 39 know that it's a mean age. That it's an age where we stop to evaluate how we've been living, whether we want to die from the way we've been living, or whether we want to enhance the quality and quantity of the rest of our lives. Or there can be environmental events. So one couple that we followed, both heavy smokers, their dog of many years died from lung cancer. That eventually led the wife to quit smoking, and the husband bought a new dog. So even the same event can be processed very differently by different people. In the addiction field, we have had the myth that people with addictions must hit bottom before they will be motivated to change. They must have a crisis. And that myth leads families and friends, physicians, and other potential helpers to sit around passively, helplessly, waiting for the person to hit bottom, waiting for them to be fired, waiting for them to have an accident, a heart attack, some other crisis that could break them out of this stuck point. We would never do that in oncology. The earliest signs of cancer would lead us to find some kind of way to help the patient progress towards taking effective action.
Okay, so this was Dr. Prochaska, the trans-theoretical model. I know you already mastered that, but I just wanted to show you what are the process, what are the stages, and how sometimes the practical effect or the communication with population can occur, and somehow what already he mentioned, that what's happening with addictive behavior. So also addictive behavior, apart from the perspectives of public health, we have to see that as a disease and using that all stages of trans-theoretical model. So I'm done on this level. So I will let you go under one condition. Do you remember that? Smile. Okay, smile. Having energy. Remember Dr. Dean Ornish. Do nice walking, breathing fresh air.